St. Vincent's Health Partners is a URAC-accredited, clinically integrated network. And what that means is that we're focusing on transitions of care that have not been focused on in the past. So today, if a patient is discharged from the hospital or from the emergency room and goes home or to a nursing facility, we're really making sure that that patient has care that's followed up at the receiving end. So each transition is paramount to good patient care in a clinically integrated network. So the barriers is how do you get that information and what is the correct information? For instance, medications are important. So when that patient leaves the hospital and goes to a nursing facility, we have to make sure that the exact medications that that patient is stable on is received by the nursing facility in order to provide good care. So if we can transmit a correct medication list, if we can transmit the correct problem list, then the moment that that patient arrives at the nursing facility, they're not waiting minutes, hours to be able to do the right thing. They're doing it from the moment that patient sits in that facility. So we do it in two ways. One is we've created a playbook, and in that playbook we articulate the minimum requirements for the transfer. So within that playbook, if a patient is going from the emergency department or from the hospital or from a clinic to a nursing facility, we ask them to send the patient's diagnosis, the exact medication list. We want it to be electronic. We're trying to incorporate all of the electronic tools so that no one has to print, copy, or handwrite anything. What we want it to do is go from system to system. Since we're not there yet, what we do is we've created a personal health record that patient takes. It is a written record from the facility that is moving from point A to point B, and within that record they're required to give that exquisite detail so that the recipient or the receiving facility has an exact understanding of what that patient needs. If you are a member of our network, it's part of our playbook and it's part of our requirements. So what we're doing is we're looking at how do we verify that record has been used. Today, because all of our members are not electronically connected, we manually ask each individual, for each patient, for each receiving facility, did you get the personal health record? Was it readable? Was it usable? Was it up to date? Was it a summary of the data of the care that was done at the facility prior to arrival? And we're doing that manually. We will do that until we can get all the electronic systems in place to do that electronically. We need patients and providers to realize that the care of tomorrow may not be in an emergency department. It may not be in a hospital. It may be at home. For instance, patients today who are admitted with pneumonia that is simple and uncomplicated may not be seen in a hospital. They may be provided short-term care in a nursing facility and then sent home, or we might be able to do more infusion of antibiotics at home for simple pneumonia. The way that we take care of patients is going to change. What we expect is the acuity or the level of sickness or the complications. The more the complications, the higher the facility. Those patients with less complications, less comorbidities, we should be using a comparable setting that may not be in a hospital today.